Al profesor Dennis hace años que no lo veo.
German, are you able to see our slides?
Wait a minute. So 1 minute. I am doing the YouTube connection, please.
I can, we can see your slides, Brad.
Okay.
In the presenter view, Dr. Calderon?
Oh, just a regular slideshow.
German, are you able to see our slides?
Wow, what is it?
I can see the slides and the presenter as well. So
Everything's
right.
okay. Sorry, guys. I've been doing the YouTube connection. Okay, we are 7 o'clock. I will give the introduction. Wait a minute, please. So I welcome to Dr. Anthony Caldamon, Director of Pediatric Urology Hospital, Children's Hospital, and also Dr. Lisa Aguiar, Assistant Professor of Surgery, Urology, and Pediatrics at Hospital Children's Hospital, USA, and Dr. Bradley DeNardo, Associate Professor of Pediatrics, Pediatric Hematology Oncologist at Hospital Children's Hospital. And welcome to the Dr. Héctor Pacheco César, consultante del Centro Hospitalar Pereira Rosell, Hospital Público del Uruguay. And also Dr. Francisco Tibor Demes, Chief of the Pediatric Urology Service at the University of Sao Paulo. Thank you guys for being with us, and thank you for accepting our invitation. Okay, Lisa, you have the screen for you.
Excellent. Thank you very much for the invitation. And today we'll be talking about Wilms tumor and current therapy and novel approaches. We have no financial disclosures, and we'll be going over today a little bit of background on Wilms tumor, and then delve into some more recent literature on cross-sectional imaging, specifically CT versus MRI. I'll talk about nephron sparing surgery and minimally invasive surgery and its uses in the setting of Wilms tumor, and then current approaches to therapy, specifically COG versus PSYOP protocols and progress in high-risk disease, including stage 4 bilateral disease and anaplastic Wilms. So a little bit about the burden and epidemiology of Wilms tumor. Renal tumors compose of 6% of all pediatric cancers, and most of them are Wilms tumor. So that makes it the 5th most common childhood cancer. As we know, most present unilateral and under the age of 2, with a peak incidence of around 2 to 3 years of age. It's classically described as a triphasic tumor that's derived from primitive metanephric blastema. And we can see here on the picture, they're typically blastomal cells, stromal cells, and epithelial cells. Of course, unfavorable histology has a poor prognosis and includes anaplasia, and that is characterized by extreme nuclear and cytologic atypia, hyperchromatic and large nuclei, as you can see in the top picture with an arrow pointing to a large nucleus, and mitotic figures in the lower picture. Around 7 to 8% of Wilms tumor patients have unfavorable histology, and of course associated with poor prognosis, resistance to chemotherapy, and most associated with TP53 mutations. We all know that there are 2 different approaches to staging treatment protocols for Wilms tumor. The PSYOP versus the COG staging is listed here. I won't go over too much detail, but the general concept, of course, is that PSYOP recommends preoperative chemotherapy and then subsequent surgery, whereas the COG recommends upfront surgical resection and then chemotherapy. I'll mention a little bit about genetic syndromes, mainly because they're at higher risk of long-term issues, including end-stage renal disease, as well as bilateral disease and multiple and recurrence. We know that WT1, WT2, and FWT1 and FWT2 are involved in the more common syndromes like Dennis-Drash, Wagger, Becker-Wiedemann, and familial Wilms tumor. The risk can be up to 50% for Dennis-Drash and Wagger, but we should consider these with regards to our treatment protocols as they are at increased risk, and we'll talk a little bit about approaches to them. Of course, you know, the syndromes are typically diagnosed first, and then screening recommendations are pretty strict in this patient population, and they include ultrasound typically every 3 to 4 months up to a certain age, depending on their risk of Wilms tumor. But there are recent advances in when to get a genetics referral, or recent recommendations on when to get a genetics referral for patients with Wilms tumor that we are somewhat concerned for an underlying cancer predisposition syndrome. And that is about 10 to 15% of our patients. The identification of these patients can, one, change cancer treatment and change our surveillance strategies, predominantly being more strict. And then, of course, genetic counseling to family members as there's an autosomal dominant pattern of inheritance with variability for some of these genetic syndromes. More recently, the McGill Interactive Pediatric OncoGenetic Guidelines came out with specific guidelines to Wilms tumor, and I'll go over them briefly. Their goal for this group's goal is basically to provide a tool to identifying patients who are at highest risk for an underlying CPS, and these algorithms provide a systematic approach to these patients. And the Wilms tumor algorithm includes characteristics, these 4 characteristics that we'll go over: age less than 2, bilateral or multifocal disease, the presence of nephrogenic breast, and overgrowth features. As you can see, having one of those automatically qualifies the patient for a genetics referral. And then if there is not presence of one of those 4 characteristics, you go to sort of the more commonly used universal criteria, which is a close family member history, and any dysmorphic or congenital anomalies that are concerning for an increased risk in Wilms tumor. When this group applied their algorithm in Toronto at the Hospital for Sick Kids, they fortunately identified 100% of children with Wilms tumor and a confirmed CPS. So they calculated odds ratios to evaluate the strengths of associations between each criterion, and it worked out well for them. So it's something to consider in working up our patients who are first diagnosed with Wilms tumor and have a question of some type of congenital, some type of CPS that we need to follow more carefully. I'll talk a little bit about imaging, CT versus MRI, and its use and benefits and disadvantages to both modalities. You know, commonly ultrasound is used first for initial diagnosis and characterization of an abdominal mass, but as we know, cross-sectional imaging is necessary for further characterizing the tumor, surgical planning, staging, and then surveillance. CT scans are typically more available. They're inexpensive, but of course they provide, a radiation exposure and increased risk to our patients that we have to keep in the back of our heads. The MRI is usually less available, expensive, and often requires an anesthetic in pediatric patients. And we'll go over the concerns about that. But one of the major benefits is that there's no radiation exposure. So radiation exposure from CT scans really became a hot topic in 2012 when Lancet published this article looking back at close to 180,000 patients in the NHS, and their risk of leukemia and brain tumors. And they found that the risk of leukemia and brain tumors were positively associated with increased doses of radiation delivered by CT and they looked at all body parts, head, chest, abdomen, and extremities. Of course, this raised concerns for younger patients who are followed for any number of reasons with imaging. And just to put this into perspective and into some context, the milligray of radiation dose ranges between 3 to 4 for a chest and abdominal CT under the age of 5. And in this study, they found that about 60 milligrays could triple the risk of brain tumors and 50 could triple the risk of leukemia. However, in our world of oncology, the clinical benefit typically outweighs the small absolute risk. So CT scans are still commonly used for diagnosis and surveillance. The risk of anesthesia more recently became a very hot topic. Around 2015, data focused on the neurotoxicity of anesthesia. And apoptosis of cells in animal models. And they looked at, commonly used drugs like ketamine and propofol. But most of these studies were, again, based on animal models. And the conclusion was that there's really insufficient human data to draw any firm conclusions. So therefore, we're sort of left with, is there any difference between these two modalities with regards to performance? And this COG study from a report from the COG compared the performance of CT and MRI, specifically looking at certain factors like capsular penetration, lymph node metastasis, tumor thrombus, preoperative tumor rupture, and synchronous contralateral lesions. And they compared it to surgical and pathological findings in their central review. And fortunately, there were really no difference with regards to sensitivity and specificity for CT and MRI. So in conclusion, I think CT versus MRI is dependent, deciding on which to use is really dependent on the institutional expertise, the availability of anesthesia, and the concerns regarding cost. We all know that cross-sectional imaging is important. There may be some benefit to consistency throughout surveillance to make it easier for our radiology colleagues to compare one, CT to subsequent CTs or MRIs. So perhaps we should just focus on staying consistent, especially in the setting of a partial nephrectomy where our radiology colleagues are looking at changes within a kidney. I'll talk a little bit about 3D printing because there's a lot of literature in adult literature to support 3D printing for surgical planning in kidney tumors. And I have found it useful in my practice for surgical planning for partial nephrectomies and bilateral Wilms. And this is a patient of mine who presented with a large right renal mass and a smaller left renal mass. And the picture on the left is sort of the initial presenting MRI. And then the picture on the right is post-chemo and right nephrectomy. I'll show you a video of our 3D printed model. And as you can see, we can choose colors for different tissue. And so blue was tumor, red is the vasculature, green is the collecting system, and white is obviously bone. And so in this video, you can see the tumor is pretty it's posterior, obviously medial, and it helped me to understand the relationship between the tumor and specifically the vasculature and the collecting system. And fortunately, surgery went well. I did use intraoperative ultrasound as well to identify, because as you can see, it's a very endophytic tumor, and we could not identify it from outside of the kidney. But I think it is a help if you have access to 3D printing. Well, I'm going to talk a little bit about nephron sparing surgery. You know, the trend in adults is really nephron sparing surgery has become sort of the gold standard for small renal masses, and we are using partial nephrectomies more and more on the adult side. And this can be attributed to improvements in technology and technique, but it also can be attributed to sort of more identifying more small renal masses incidentally on imaging. And as we know, that's not as common in the pediatric population. Only about 7% of renal tumors are treated with nephron sparing surgery in pediatrics. And the lessons that we've learned from the adult literature is that it's beneficial due to lower rates of GFR decline, lower risk of cardiovascular decline, and at least in the adult literature, it provides equivalent oncologic outcomes. It's pretty much the gold standard for T1 tumors, and some urologists are using it for T2 tumors. And just to remind you, T1 tumors are less than 7 centimeters. And as we know, that is typically not how Wilms tumor presents. And we are dealing with a larger tumor with less healthy kidney to work with. So that's probably the main reason why nephron sparing surgery is not as common in the pediatric population. In addition, I think, you know, it's important to remember that children are therapeutic orphans, as Harry Shirkey said. There are a lack of studies addressing safety, efficacy, and dosing in children. For example, only 16% of the World Health Organization clinical trials are dedicated to pediatric topic. And we face, you know, challenging ethics and fear of hurting children. And oftentimes we think about the heavy consequences. For example, in Wilms tumor, you know, the fact that tumor spillage doubles the risk of death obviously causes a little bit of anxiety with regards to nephron sparing surgery. But I'll talk a little bit about how successful it has been proven to be with correct patient selection. So So historically, nephron sparing surgery was reserved for bilateral Wilms tumor or children with a solitary kidney. But now we consider it for patients with syndromes that predispose them to patients to renal failure or multiple lesions in the contralateral kidney. And then SIOP made recommendations concerning nephron sparing surgery in unilateral Wilms tumor, and specifically mentioning patients with stage 1 disease and a well-defined tumor, no invasion of tumor into the renal vessels or collecting system, and a good response to chemotherapy, and intraoperative histologic confirmation of tumor-free margin. It's the SIOP approach to Wilms tumor lends itself a little bit more easily to nephron sparing surgery due to the pre-op chemotherapy and goal of shrinking the tumor first. So it's not surprising that most of the data comes from countries that follow SIOP protocols. This study, for example, is a retrospective review focusing on unilateral Wilms tumor managed with nephron sparing surgery in 37 patients who underwent a nephron sparing surgery off protocol in Germany. The average age was 2.5 years, and 76% of these patients had stage 1 disease versus 51% of the radical nephrectomy patients. There was no statistically significant difference in relapse-free survival between a radical nephrectomy or neoadjuvant chemotherapy plus partial. So that's positive, but we have, and these are the considerations for nephron sparing surgery as mentioned in the prior slide. In addition to, we should mention that there were greater than 50% of kidney remaining after nephron sparing surgery in this study. A study out of Toronto was also published a retrospective review of only 8 partial nephrectomies, 7 presenting with unilateral disease, and the average tumor size of node was 2.5 centimeters, so very small. These patients had predisposing syndromes and were being properly followed and likely picked up early on with regards to size. Their mean follow-up was 36 months, and all of their patients had normal creatinines throughout follow-up, and only a quarter of them developed hypertension, and there were no recurrences. So with regards to nephron sparing surgery in general, I think that the quality of data is lacking a little bit because we're looking at mostly small single institution case series, and these studies are subject to significant selection bias and reporting bias because we all know that we're less likely to report poor outcomes versus success stories. But it does seem to show that there's similar tumor rupture, recurrence, end-stage renal disease, and overall survival outcomes. So it could be more the future of treatment of Wilms tumor, of course, for appropriate patients selected carefully. And we have to consider tumor size, tumor location, and the residual amount of healthy parenchyma when selecting these patients. And I think, nephron sparing surgery in unilateral non-syndromic Wilms tumor is controversial, and appropriately so, because the gold standard provides, a radical nephrectomy provides such good outcomes. So minimally invasive surgery has been around for a while, much longer than this initial study, and I think we all can recognize Dr. Tibor Dennis's name on this. But this is the first study showing demonstrating laparoscopic surgery for Wilms tumor, and it describes 2 patients with significant decrease in size in their tumors after preoperative chemo, and they were both kidneys were both removed successfully without rupture via a small 4 centimeter fan and steel incision. And these patients were discharged home post-operative day number 2, and there were no post-operative complications. More recently, there have been studies published, this one out of Toronto, looking back at their experience with laparoscopic surgery on kidney tumors. And as expected, similar to other studies demonstrating benefit, they found that there's shorter length of stay, 3 versus 6 days, decreased postoperative narcotic use, and in this study, decreased use of NG2 postoperatively, and there was no increased length of procedure time and tumor rupture. Obviously, skilled hands if there's no increased length of procedure time. It should be noted that the mean size of the tumor for laparoscopic patients was smaller, and that's appropriate as there's obviously patient selection bias. This retrospective study of 32 patients using videolaparoscopic versus, and looking at videolaparoscopic versus open approach is the first and I believe still the only direct comparison specifically to Wilms tumor. And they included 15 open versus 17 lap. And again, Dr. Tibor Dennis is on this paper, so out of Brazil. And the laparoscopic approach, patients had fewer lymph nodes harvested, longer operative times, shorter length of stay, and event-free survival was similar. Again, noted, their tumors were smaller in size. And in this study, which is the largest series, looking at SIOP 2001 data, included a retrospective study of 24 unilateral Wilms tumor between 2001 and July 2013. All received preoperative chemotherapy, obviously, and the mean tumor volume decreased in size significantly to around 73 cc's at the time of surgery. Their mean follow-up was 47 months. And the results included only 1 intraoperative complication, which was a splenic injury that was appropriately treated, no intraoperative tumor rupture, 1 local recurrence, and lymph node sampling was adequate. Only 2 patients, and this could be just lack of prioritizing lymph node sampling on the surgeon's part, perhaps. So they concluded that the treatment results were comparable to those of open surgery. Of course, robotic surgery is up and coming or has been around, but more commonly used in kidneys in children for other pathology. And the advantages include 10 times visual magnification, 3D visualization, and tremor filtered instruments. That perhaps the future of Wilms tumor is a crossover between nephron sparing surgery and minimally invasive surgery. This, I believe, is the first case report using the robotic technology in a nephron sparing approach. And it's one to consider in the adult literature as well as in the pediatric literature. Outcomes have been similar with robotic technology compared to traditional stick laparoscopic approach. And so perhaps this is something to consider. Of course, in the adult world, most partial nephrectomies are now performed with robotic technology, and the advantages are as listed, but in the pediatric world, we have yet to adopt this for cancer surgery. So that concludes my section of the talk. I'll hand this over to Brad DiNardo.
Thanks so much, Liza. So I'll start by saying that from the oncologist perspective, Wilms tumor really represents one of the greatest success stories in terms of childhood cancer and really in modern medicine, generally speaking. This was a disease that historically, when treated with surgery alone or early attempts at surgery combined with radiation, had survival rates less than 30%. And we've seen with the evolution of collaborative group clinical trials, primarily through the National Wilms Tumor Study Group and PSYOP, that outcomes are now, for all comers in Wilms tumor, approaching or even above 90%. A lot of this has recently been driven by our ability to really refine risk stratification so that we've been able to identify patients most currently who can actually be managed with a decrease in treatment intensity so that we can avoid some of the long-term side effects of therapy. But with that being said, we still have subgroups of patients in Wilms tumor who have less than ideal outcomes. Obviously, patients with relapsed Wilms tumor do quite poorly. And in addition, we have the subgroup of Wilms tumor survivors who suffer from relatively severe debilitating long-term effects. But what I'm going to focus my talk on is the subgroups of higher risk Wilms tumor in which outcomes in terms of survival have been suboptimal. That includes patients who present with metastatic disease, those who have bilateral disease at diagnosis, and of course, patients with anaplastic Wilms tumor. But just to put this into brief historical perspective, and Liza already touched on this already, is that our standard of care currently for Wilms tumor has really been driven by these two major treatment strategies from the NWTS, which is now Children's Oncology Group Renal Tumor Committee, and that of PSYOP. And although much of these treatment strategies are similar, they have the major difference of COG-guided institutions pursuing upfront nephrectomies at diagnosis for Wilms tumor, with countries who follow PSYOP pursuing neoadjuvant chemotherapy, followed by nephrectomy. For upfront nephrectomy, the implications are that we are achieving an immediate, accurate histologic diagnosis, and that we are staging these patients, surgically staging these patients based on the natural history, the natural biology of their disease. In addition, this allows us to avoid chemotherapy for patients who fit our very low risk criteria. But of course, the disadvantage of the COG approach is the increased risk of surgical complications, primarily the higher risk of tumor rupture when doing an upfront nephrectomy on typically large Wilms tumors. The implications for the PSYOP approach in terms of doing neoadjuvant chemotherapy is that this has been demonstrated to improve surgical outcomes and allows for downstaging of tumors in the setting of the preoperative chemotherapy. It also allows for an assessment of just how chemosensitive these patients' Wilm tumors are. And of course, the major disadvantage to this neoadjuvant chemotherapy approach is the risk of treating patients with neoadjuvant chemotherapy in the setting of their diagnosis not ultimately being Wilms tumor. And so that misdiagnosis rate, which is now currently quoted between 1% and 2%. But what's important to keep in mind is that both of these treatment strategies, the COG and the PSYOP, have excellent and comparable clinical outcomes. Our modern therapy has really been driven by the observations and conclusions of a set of serial clinical trials by NWTS and PSYOP from the late 1960s through 2000. And what we've recognized through this set of collaborative clinical trials is that really vincristine and dactinomycin form sort of our backbone chemotherapy regimen, with doxorubicin being used for patients with more aggressive disease. These studies have also demonstrated how important of an adverse prognostic factor tumor spillage is with regards to overall outcome and recurrence. It's also defined the use of radiation for patients with stage 3 abdominal disease. And more recently, these trials have demonstrated our ability to decrease treatment intensity for the lowest stage, lowest risk patients. And this historical group of trials has really achieved excellent outcomes. As you can see here, comparing the survival rates between the NWTS 4 and 5 trials and some of the patients on PSYOP 9 and PSYOP 93, these historical trials were already achieving event-free survivals typically higher than 80% and corresponding overall survivals upwards of 90%. This is just a brief overview of what is considered current standard of care for PSYOP following institutions based on the PSYOP 2000 clinical trial, which is the most recently completed trial through PSYOP, which just briefly, again, takes a patient newly diagnosed with Wilms tumor, newly diagnosed with a renal mass, I should say, through 4 to 6 weeks of neoadjuvant chemotherapy, followed by surgical resection of their primary tumor. Post-operative chemotherapy and adjuvant radiation is dictated according to the histology of the tumor following that neoadjuvant chemotherapy and some additional clinical or biological factors. In contrast, our current standard of care through the Children's Oncology Group following institutions is based on 3 clinical trials run in parallel for our very low, and higher risk Wilms tumors, as well as our anaplastic Wilms tumor, which again is calling for an upfront surgical resection in which we are initially defining surgical stage histology that is a pre-treatment histology, and then utilizing certain clinical factors as well as certain molecular findings, specifically loss of heterozygosity at combined 1p and 16q, to define what the adjuvant chemotherapy and radiation will include. But what these clinical trials have really sought to do is advance treatment and improve outcomes for the subgroups of Wilms tumor patients who have historically not done as well. And that's highlighted in this long-term data from the NWTS4 clinical trial. So it's those patients who have stage 4 metastatic disease, 25% we should expect to relapse. Additionally, patients who have bilateral stage 5 Wilms tumor who also suffer from worse outcomes. And of course, patients who have anaplastic histology who suffer the worst. And so going forward, I'd like to focus on what progress we've made in those 3 subgroups of patients, starting with patients who have had stage 4 metastatic disease. So as we know, blood-based metastases in Wilms tumor occurs in around 15 to 20% of cases. The overwhelming majority of metastatic disease is pulmonary Mets, and we've seen a gradual increase in incidence of pulmonary Mets in Wilms tumor attributed to the high in routine use of chest CT versus chest X-ray at diagnosis in these patients. And we know that patients with metastatic Wilms tumor suffer from inferior outcomes, but it's not just on the basis of an increased risk of relapse and decreased overall survival, which historically, we quote around 25%, but also on the basis of increased late toxicity from these patients, as historically we've tried to maximize their treatment regimens with whole lung radiation and high doses of anthracycline-based chemotherapy, which has resulted in this subgroup of patients experiencing high rates of cardiac dysfunction, pulmonary toxicity, and a risk for secondary cancers related to the treatment itself. A real paradigm shift in how we approach these patients developed with the PSYOP 93 protocol, in which the use of whole lung radiation was based on selecting patients who had a favorable or unfavorable response of their pulmonary metastases to 6 weeks of initial chemotherapy. What happened on this trial is that patients received 6 weeks of a standard chemotherapy regimen that included an anthracycline, and then at the time of their nephrectomy, they underwent a repeat CT chest to assess their pulmonary metastatic disease. This study encouraged pulmonary metastatic resection to be able to get patients to a place where they had no further lung nodules. And so those patients who combined surgery and chemotherapy resulted in a complete response of their pulmonary Mets at 6 weeks, did not go on to receive whole lung radiation. And that accounted for a really substantial portion of patients on this trial. And although the outcomes on SIOP 93 were equivalent to historical and other clinical trials going on at the same time, what they were able to do was demonstrate that you could avoid whole lung radiation in the overwhelming majority of these patients and achieve similar outcomes. We should keep in mind that these patients did receive a high cumulative dose of anthracycline, but it was these results that really formed the basis for our most recent study in patients with stage 4 metastatic Wilms tumor, and that's the COG-AREN 0533 study. This study took on a similar strategy to that of SIOP 93, in which patients who had favorable histology Wilms tumor with pulmonary mets were treated with, after an upfront nephrectomy, I should say, they were treated with 6 weeks of standard chemotherapy, nearly identical to the SIOP protocol. This study did not encourage pulmonary metastatic disease resection and based the role of whole lung radiation simply on response to chemotherapy. But those patients who had a complete response of their pulmonary nodules and no unfavorable molecular features were eligible to move forward without lung radiation and complete standard chemotherapy, whereas those patients who did not have complete resolution of their pulmonary mets received standard whole lung radiation and an intensified chemotherapy. The outcomes of this study are really profound, and I'll take you through this. So they enrolled almost 300 patients, and based on chemotherapy alone, they were able to avoid lung radiation in 42%, so almost half of their patients. And they achieved outcomes demonstrated in the 2 Kaplan-Meier curves here on the right of the slide that were statistically significantly improved to historical comparators, that being NWTS5 being the blue line here in terms of event-free survival, and the yellow line being this current study. Similar for overall survival. These are the best reported outcomes in metastatic Wilms tumor, and not only did this study achieve the best outcomes, but they did it by avoiding whole lung radiation in almost half the patients and administering a relatively low cumulative dose of anthracycline-based chemotherapy. So really, really outstanding results that has formed our current standard of care for patients with metastatic Wilms tumor. And in the current SIOP 2016 protocol, a similar strategy is being pursued in an effort to minimize whole lung radiation and low cumulative doses of cardiotoxic chemotherapy. Switching gears, we'll review what progress we've recently made in treatment of bilateral Wilms tumor. So we know that about 5 to 8% of all Wilms tumor patients will present with synchronous disease in both kidneys, and that historically these patients have suffered from inferior outcomes. On NWTS5, they had 4-year event-free survival about 50%. The SIOP experience shows overall survival of 69% at 10 years. In addition, we know that patients with bilateral disease run a high risk of developing end-stage renal disease and requiring dialysis and possible renal transplant later in life. The reason that outcomes have been poor in bilateral disease are obvious in some respects and not obvious in other respects, but historically these patients have been treated with highly variable institution-dependent treatment approaches. We also know that patients with bilateral Wilms tumor do worse because there's a higher incidence of anaplasia, and in many patients who undergo biopsy, either at diagnosis or early into treatment, oftentimes that anaplasia can be missed. In addition, as Liza has mentioned, nephron sparing techniques for pediatric patients with bilateral Wilms tumor have been relatively slow to evolve, but probably the most important reason that bilateral patients have done poorly historically is an overall delay in managing them surgically. So these patients have historically been prone to these prolonged courses of preoperative chemotherapy. On one of our previous studies, I think the median duration of preoperative chemotherapy before local control was 7 months. And the reason that this is because these patients tend to have a higher incidence of anaplastic tumors, which respond poorly to neoadjuvant chemotherapy. But they also may have stromal predominant histologies, which we know are also tumors that, although have good prognosis, do not respond well in terms of size of the tumor to chemotherapy, or they can be tumors that undergo rhabdomyomatous differentiation and also don't decrease in size while receiving neoadjuvant chemotherapy. So here at the bottom is an example of a recent patient of ours with bilateral Wilms tumor presenting with a large right renal mass who after 6 weeks of chemotherapy had no appreciable change in the size of the tumor. Ultimately, we underwent a right-sided total nephrectomy at 6 weeks, and this patient had stromal predominant histology. And historically, patients like this would move forward with more and more chemotherapy, potentially intensified chemotherapy, but not achieve any real significant effect in terms of size of their disease burden. So the Children's Oncology Group, recognizing this landscape for bilateral Wilms tumor, formulated the first prospective clinical trial for patients with bilateral disease. And the treatment scheme is here on the right, which is complex, and only put it here to point out that this was a 3-arm study. It enrolled patients who had bilateral Wilms tumor, also patients who had unilateral Wilms tumor but were predisposed to bilateral disease in the setting of diseases such as Denny's-Drash or Beckwith-Wiedemann, and also an arm for patients with diffuse hyperplastic perilobar nephroblastoma, of which the results have yet to be published. The overall treatment strategy for this trial was to treat all patients with 2 cycles of neoadjuvant chemotherapy, followed by repeat imaging at 6 weeks, and encouraging bilateral partial nephrectomies at 6 weeks if feasible for patients. For patients who at 6 weeks had only partial response, not amenable to bilateral partials, the recommendation was for 2 additional cycles. And for those patients who had no response, the recommendation on this trial was for open bilateral biopsy. And then what the trial called for was definitive surgery regardless of response at 12 weeks, followed by adjuvant treatment that was based on the stage of on the highest stage of the tumor and post-chemotherapy histology. These results were published just a few years ago, and I'll show them here. So they really achieved great outcomes with this standardized approach. So nearly half of the patients on this trial underwent a surgical local control that consisted of a unilateral total nephrectomy and a contralateral partial nephrectomy. But about 35% of patients were amenable to bilateral partial nephrectomies, and only 2.5% of patients required bilateral total nephrectomies. And the outcomes on this clinical trial were really substantial. So 4-year event-free survival of 82% and 4-year overall survival of 94%. Recommended tremendous, were really tremendous gains from patients with bilateral Wilms tumor treated previously, as demonstrated here in this Kaplan-Meier curve. So really, these excellent outcomes were achieved by this standardized approach to both preoperative chemotherapy and histology-driven postoperative chemotherapy, with treatment being intensified for those who had unfavorable histology. The excellent outcomes were also on the basis of encouraging nephron-sparing surgery for these patients, but perhaps the most impactful portion of this trial was encouraging surgical resection within 12 weeks of diagnosis, which was able to be achieved in 84% of patients. And so on the basis of these results, PSYOP has on their recent 2016 study also recommended a maximum of 12 weeks of pre-op chemotherapy for patients with bilateral Wilms tumor. Switching gears and talking about the final subgroup of Wilms tumor patients with poor outcomes, we're going to review anaplastic Wilms, which is obviously the subgroup of patients who we have the most challenging treatment course and worse outcomes. So anaplastic Wilms tumor occurs in about 7.5% of all Wilms tumor and can be either focal or diffuse. We now recognize it as the most powerful adverse prognostic factor in Wilms. It has a high concordance with TP53 mutations, which is demonstrated here, and also about a 30% association with McGill amplification. So molecular abnormalities that within the field of oncology we know indicate very aggressive malignancy. Diffuse anaplastic Wilms tumor patients suffer the poorest outcome. And that's demonstrated here in this chart below. So historically, these patients have been treated with gradually intensified chemotherapy regimens. And with that approach evolving over time, outcomes for patients with stage 2, 3, and 4 disease have gradually increased. But on NWTS5, the outcomes still were quite suboptimal, including patients with stage 4 disease who had 4-year overall survival of only 32%. The PSYOP experience with diffuse anaplastic Wilms tumor is recently published in the literature. This year in the European Journal of Cancer were the results of the PSYOP 2001 protocol for patients who had stage 4 high-risk Wilms tumor, which included this subgroup. And the treatment recommended on this clinical trial for these high-risk patients included a 6-drug intense chemotherapy regimen given over 34 weeks, depicted here, with maximal surgical resection of both the primary tumor and all sites of metastatic disease, as well as a really aggressive radiation approach for these patients. Just to show how rare, thankfully, how rare these patient subtypes are, they only enrolled 74 patients over 12 years, and only 40 of them were diffuse anaplastic Wilms tumor. And I'll just point out, to speak to the aggressiveness of this disease, that for the 40 patients with diffuse anaplastic Wilms receiving 6 weeks of neoadjuvant chemotherapy, there were 6 patients, a substantial proportion, who progressed on this chemotherapy regimen, all of which died of disease, and 5 patients who only had stable disease in the face of this neoadjuvant regimen. 4 of those patients died of disease. Unfortunately, the outcomes for these patients treated on PSYOP 2001 were no different than historical comparators, as depicted here in these 2 Kaplan-Meier curves. The green curve is the diffuse anaplastic Wilms tumor patients, in which 5-year event-free survival was 28% and overall survival was only 29%. One treatment strategy that is considered more in PSYOP countries is the use of autologous stem cell rescue for patients with diffuse anaplastic Wilms. This is a treatment strategy that has been reported for a long period of time in patients with relapsed Wilms. Just really quickly, this is the process of mobilizing, collecting a patient's own stem cells prior to treating them with high-dose myeloablative chemotherapy regimens, which require reinfusion of those patients' stem cells so that they can appropriately recover from the toxicity of that chemotherapy. So in the relapsed Wilms tumor setting, there's abundant retrospective data utilizing this treatment regimen. There are no prospective studies. There are no randomized studies. There are sort of meta-analyses of the literature in which there may be a trend towards a benefit for this treatment regimen for patients with Wilms tumor. But it is a consideration for diffuse anaplastic Wilms tumor. The other strategy to potentially improve outcomes for these patients with diffuse anaplastic Wilms is what the Children's Oncology Group has taken on. And that is sort of intensifying treatment to sort of the brink of what we consider acceptable toxicity for these patients. And the results of this approach were just published in the Journal of Clinical Oncology a few months ago. This is the Children's Oncology Group AREN 0321 study, which included patients who had stage 2 to 4 diffuse anaplastic Wilms tumor. What this study did was treat these patients with a regimen that we call the UH1 regimen, which is a highly toxic 5-drug chemotherapy regimen given over 30 weeks' time. But the experimental portion of this treatment was taking patients who had stage 4 diffuse anaplastic Wilms tumor, who had measurable disease that we could assess response to. And again, just bearing in mind that all these patients were undergoing upfront nephrectomy before getting these treatment regimens. So those patients who had metastatic anaplastic Wilms, who had measurable disease that we could follow, were eligible to receive what we call an irinotecan window. So they were exposed to irinotecan, a chemotherapy medication that we've had a lot of experience with that's not used commonly in Wilms tumor, but has a lot of preclinical data to suggest efficacy in Wilms. So patients would receive 2 cycles of irinotecan and response would be assessed. And if patients' metastatic disease demonstrated imaging evidence that they responded to irinotecan, then they added irinotecan to the UH1 regimen and called that the UH2 regimen. So really, really pushing the boundaries of what we can do in terms of acceptable toxicity for treatment. They only had 14 patients who ultimately received this irinotecan window, but 10 patients had a partial response and 1 patient had a complete response with regards to their metastatic disease, demonstrating that, that this drug is very active in patients with anaplastic Wilms. The toxicity of this treatment, the toxicity burden was high. And so I'll just go over that before we go over the results. So 6% of patients, so 4 out of 66% of patients on this trial died as a result of the treatment itself, which is in the world of pediatric oncology, a very high toxic death rate. 3 of those patients died while on therapy, and they were between the ages of 3 and 5, and all from cardiac related issues. So 1 patient of cardiomyopathy, another patient died of CHF, and another patient died of pulmonary edema secondary to left ventricular systolic dysfunction. A subsequent patient died after completion of treatment from cardiac failure as well. So really, really profound to consider patients so young dying of heart disease from treatment. But with that being said, outcomes were improved on this treatment regimen. So this is Kaplan-Meier curves looking at all patients with diffuse anaplastic Wilms tumor stage 2 to 4 on this treatment regimen. This is event-free survival in blue compared to the NWTS5 trial. Not statistically significant difference. Similar, there was not a statistically significant difference in overall survival, although a trend towards improvement in survival. Where there was a statistically significant difference in improvement is in relapse-free survival. So what this is reflecting is that the intensified chemotherapy regimen perhaps provided better disease control and less relapse, but was counterbalanced by the effects of the toxicity of this treatment regimen and patients dying due to the treatment itself. But regardless, the overall outcomes were encouraging considering the patient cohort that we were managing. And this is my final slide, teasing out the outcomes according to stage of disease. So patients who had stage 4 diffuse anaplastic Wilms tumor on this treatment regimen had 4-year overall survival approaching 50%, which historically is a good number. So the patients who received the irinotecan treatment had at least as good outcome as the patients who did not receive irinotecan, despite the fact that this was a group with measurable metastatic disease, so presumably more aggressive disease. And so on the next generation of our COG study, we'll include irinotecan for all patients with anaplastic Wilms, and will provide a number of measures to try to minimize toxicity. So in the SIOP strategy, as proposed in 2016, it's relatively nebulous in terms of how to manage these patients, given the lack of a real standard of care. But the suggestion that a regimen like the one used in this trial with the addition of irinotecan and possibly a consideration of autologous stem cell rescue would be beneficial. So generally speaking, we made tremendous progress with regards to treatment of some of our higher risk subgroups of Wilms tumor, but diffuse anaplastic Wilms tumor remains a disease where outcomes have yet to be substantially improved. And so with that, Liza and I will conclude the talk. As Liza reviewed, our major conclusions that genetics referrals to identify patients who have underlying cancer predisposition is sort of an emerging area in Wilms tumor. The decision to use CT versus MRI imaging of the abdomen, it should be based on institutional expertise, considering the availability and risks of anesthesia, as well as the exposure to radiation with CT. Liza mentioned how partial nephrectomy has a well-described role in the treatment for bilateral Wilms tumor, but is slowly evolving for unilateral patients, and how minimally invasive surgical results are comparable to those of open surgery, but patient selection is important. And I hope that I've been able to show, to demonstrate to you that modern treatment strategies for Wilms tumor have really resulted in excellent outcomes for the majority of Wilms patients, and that recent advances in COG and PSYOP have led to improved outcomes for our higher risk subgroups. And so with that, I think we'll conclude, and we are happy to take any questions that people may have.
Okay, guys, thank you very much. Could you send me the screen for me, please? Thank you. Okay, we have actually we have questions, and I will pass this question first to the talkers, and then to the Dr. Francisco Dennis and Dr. Hector Pacheco, our expert opinions.
Yes.
Okay.
I have a question.
Wait a minute, un ratito, Hector. I will pass the question first. Voy a pasar las preguntas primero, okay? The first question is, on bilateral Wilms tumor, do you use an ice to freeze the kidneys during surgery, or you do think it is not necessary? Para la cirugía, ¿ustedes hacen el uso de hielo o hallan que esto no es necesario? Lisa?
Yeah, I have not used ice. I've been happy with just warm ischemia time and try to limit my clamp time less than 15 to 20 minutes. So working fast. Fortunately, we haven't had the need for, the sizes of our partial nephrectomies. I have not considered using ice. Yeah.
Tony?
No, I have not used ice for any of these procedures either. I agree with Liza's plan.
Could I make a comment? When in the case when we plan bilateral partial nephrectomies, I try to use ice. So this is the time when I use. In unilateral cases, no, I don't use.
I think you have to consider the cumulative clamp time in those patients, and for bilateral disease, that's perfectly appropriate. I think in the adult literature, using ice has not panned out, obviously, for unilateral tumors to be beneficial. So I haven't used that in my practice.
Héctor, por favor. ¿Usan hielo en las cirugías?
I don't use, no usamos hielo.
Thank you. Another question we have, I will translate because, sorry. When the suprarenal gland bilateral is compromised, which is your strategy?
I apologize.
In bilateral tumors?
I'm sorry?
When the suprarenal gland is compromised in bilateral tumor, which is your strategy?
On both sides?
On both sides, yes.
Fortunately, I haven't been in that situation. So I obviously try to preserve the adrenal gland because it's less than 2%, I believe, of patients involved, the tumor involves a renal gland, and there's typically a good plane. I don't know, Dr. Caldamone, have you ever had a patient with bilateral adrenal involvement?
I've not seen that. No, I haven't had any experience with bilateral adrenal involvement.
Yeah.
So it's not been the situation that I've seen. Francisco, what about you?
No, I haven't. In case with bilateral partial nephrectomy, I always spare the adrenals.
Sure.
I can speak to experience with a different disease process, and that's neuroblastoma in patients with widely spread metastatic neuroblastoma. I've encountered patients who have had to have surgical removal of both adrenal glands for management, and just requires a coordinated effort pre and post operatively with our endocrinology colleagues for managing the adrenal compromise in the immediate post operative setting and long term.
Yeah, I mean, I guess my only experience would be with adults with, solitary kidneys and renal tumors, and having to take the adrenal gland, and the adrenal insufficiency has always been managed again by even with partial adrenal gland removal by endocrinology. I fortunately haven't encountered that.
Héctor, ¿alguna experiencia con invasión suprarrenal?
Nunca tuve invasión bilateral en tumores bilaterales, pero yo creo que uno debe ser conservador, salvo que haya una infiltración muy clara. Uno tiene que ser conservador de la glándula.
Yeah. Again, I think the data suggests that there's definitely less than 5% of renal tumors involve the adrenal gland, and there's typically a clean plane between that, and that's been my experience overall.
Okay, guys, we have another question. Which is the actual role of the resective surgery in pulmonary metastases?
That's a good question. I think it depends on the approach that you take. There's good data to suggest that patients who have pulmonary metastases which fail to respond appropriately to chemotherapy have improved outcomes if it is feasible to resect those lesions. Our approach within COG is that we tend to avoid metastasectomy of pulmonary nodules unless they are unless it's questionable whether it is persistent or progressive disease, in which we in those situations we like to try to biopsy them. The majority of pulmonary mets in Wilms tumor are thankfully superficial, so can be resected, and generally speaking are responsive to chemotherapy. But as opposed to our experience with malignancies like osteosarcoma, where it's an absolute mandate to resect all pulmonary mets, given the radiation sensitivity of these lesions, you're not mandated to resect all pulmonary mets, and we don't typically pursue that path, at least here in North America.
Francisco?
As far as we're using the COG treatment, most of the cases that we have pulmonary metastases have a good response with the treatment. So I don't remember any case that we had to do surgical resection of the pulmonary lesion, at least not in our hands.
Héctor, por favor.
Solo una cosa para tenerla en cuenta, de que cuando uno va a hacer una metastasectomía en un Wilms, debe tener una imagen muy fresca, porque me ha pasado que la he ido a sacar por toracoscopía y después es tan grande que termino haciendo una mini toracotomía para sacar la metástasis.
Thank you. Which is the relation in thrombosis of vena cava? It's good to use the chemotherapy preoperative?
If there's vena cava involvement.
Sure. So if the vena cava involvement is above the hepatics, then certainly the use of preoperative chemotherapy is advised, with the goal of shrinking tumor burden. But below the hepatics, I think cross-campling the IVC, and the only extreme precaution I've taken is to, in cases with IVC thrombus, is to potentially cannulate for possible ECMO in patients, but I have not, used preoperative chemotherapy for tumors below the hepatic.
Francisco?
Yes, the same good results with the CR protocol we have in these cases with intracaval tumor invasion of the cava, and we have regression of their size that is very evident, although we have cases that we have to resort to those very remaining thrombus. We have to do even open heart surgery to remove those. But in general, they respond very well to neoadjuvant chemotherapy with a significant reduction of the sizes.
Anthony?
Sorry, I missed the question.
Okay, when thrombosis of vena cava, it's good to use the chemotherapy preoperatively?
Well, I think it depends on the extent of the thrombus, quite honestly, and whether it extends into the hepatics or not. So I think it's variable as to whether you go with preoperative chemotherapy or not.
Héctor, el uso de la quimioterapia preoperatoria en trombosis de vena cava.
Yes. Chemotherapy preoperative.
Yes. ¿Cuál es tu posición? ¿Usas? ¿Sí? ¿Estoy correcto? O sea, ¿usas quimioterapia?
Yes.
Preoperativa. Okay. Another question. I would like to know the percentage of laparoscopic do you do for ENSS?
You repeat the question?
The percentage of laparoscopy do you use in NSS?
Nephron sparing surgery.
I have not used the laparoscopic approach for nephron sparing surgery.
Okay.
Neither did I.
Later. Okay. Tony?
Have not.
Not. I know that. Okay, we have another question here. Patient with bilateral lungs metastasis with persistent after chemo and radiation, mets on the lung were removed after treatment and reports necrosis. Would you remove mets on the other lung or just observe?
Yeah, that's a really good question, and there's no straightforward answer to it. I think it has to be an individualized decision based on the patient, and specifically based on the histology and how amenable the mets are in the other lung. It is possible for pulmonary mets to have disparate findings on pathology. So you can remove some mets that do demonstrate necrosis and other mets that could demonstrate viable disease. So it has to be done on a case-by-case basis.
Okay. Francisco?
I have no experience with this situation.
Tony, Hector?
The same.
Yeah, nothing to add to Brad's comments.
Okay. Do you think nephron sparing surgery for unilateral Wilms tumor will be the standard conduct, or we farm from it?
I think if it does evolve, it will evolve in the PSYOP setting first, clearly.
Yeah, I can't imagine the COG countries adopting this widely. But the PSYOP countries obviously have an advantage with smaller tumors and more defined capsules around the tumor. Patient selection, I think, is key here. And I'm not sure, in the literature that I reviewed, if I were to pick sort of a common trend, tumors were in general less than around 5 centimeters or less, and preservation of at least 50% of the kidney was the goal. And I think that's a difficult, that's an excellent sort of patient, those are excellent patient characteristics, but rare patient characteristics. So I don't know if that's the future of Wilms tumor, but certainly consideration for other tumors of the kidney. You know, again, probably more advanced future for PSYOP countries compared to COG.
Yeah, and I'll just add that I think it'll be really interesting going forward into the future to see how the COG treatment approach responds as minimally invasive approaches and nephron sparing surgery evolves and becomes more and more prevalent, because based on our current treatment strategy, which we've been married to for over 50 years, you know, treatment is based on upfront resection of, generally speaking, large tumors that are not amenable, typically not amenable to these types of techniques that are only going to become more and more prevalent going forward. So it'll be interesting to see how things evolve over time.
And I have not encountered personally a patient with bilateral Wilms who's undergone neoadjuvant chemotherapy in which I have felt comfortable doing bilateral partials yet. I mean, so all of our cases have been a radical nephrectomy first on the larger tumor side and a partial in the contralateral kidney. So,
Francisco?
Yes, I endorse what Liza said, because those patients with in whom we could do a partial nephrectomy, unilateral tumor, have to have a very small polar tumor to undergo such procedure. So they have to be highly selected, and actually I'm very anxious to have one of these patients to try with the laparoscopic procedure. But in the sick kids of Toronto, they described the maneuver that they dissected the kidney that had a lower pole tumor, and they dissected laparoscopically, then exposed it through a very small incision, this pole, and managed to do a partial nephrectomy, an open partial nephrectomy with a very small incision. So this could be also some kind of approach for these tumors.
I suspect that we're probably going to be seeing more advances in minimally invasive surgery rather than nephron sparing surgery in the setting of Wilms, because these tumors are perfectly amenable to our minimally invasive techniques, but not necessarily amenable to nephron sparing surgery.
Anthony?
I don't think I could add much to that except emphasize the fact that until we're seeing smaller tumor sizes, at least in North America, which we're not seeing much of that particular population, I don't see nephron sparing surgery being advanced very far.
Hector, tu experiencia?
I believe in nephron sparing surgery in unilateral Wilms. Yo creo en la resección, en la nephron sparing surgery en el Wilms unilateral, pero en pacientes seleccionados, obviamente.
Guys, we have completed our time, and I do appreciate all your presence. Lisa, Brad, thank you very much for your wonderful talk. And we do really appreciate very much. Anthony, always, your presence is very important here with us. And Francisco, vou falar no idioma por respeito à pessoa. Francisco, muito obrigado, viu? Muito obrigado pela sua presença. Se você
prazer muito grande.
Se você quiser fazer algum comentário a respeito à sua experiência com a minimal invasive laparoscopic surgery, you can do that, please.
Answering to Herman's suggestion, just to mention that indeed we've been performing laparoscopic nephrectomy in these cases, unilateral tumors, after neoadjuvant therapy but these are very selected cases which had a reduction of the tumor size. So we do not try to remove tumors that remain large, that we couldn't even take it out through the fenestrated incision. So if it crosses the midline, it's not a patient for laparoscopic nephrectomy. So it has to be done with preoperative chemotherapy, and depending on the size of the tumor, we are very secure in indicating this procedure.
Héctor, por favor.
Tengo una pregunta para todos. Prolonged urine leakage, intraoperative blood loss, and positive margin are more common in patients undergoing nephron sparing surgery compared to radical nephrectomy. However, complications can be managed acceptably. This suggests that an aggressive approach to nephron sparing surgery in patients with bilateral Wilms tumors is safe and appropriate. What opinion deserves the positive margin? The fact is, if you have positive margin, that obviously need higher intensity of therapy. Have you used the frog sensation to help?
Lisa, maybe you can answer. Or
So the question is, with regards to
Positive margins in bilateral Wilms.
positive margins in a bilateral Wilms patient? Is that?
¿Es la pregunta, Héctor?
Serve the positive margin, and have you used frozen section to help?
Frozen section.
Oh. I have used frozen section in one particular patient, but for the majority of patients, I have not. If I see clean kidney tissue, then I don't send off a frozen section. Fortunately, the frozen section I did send off in one patient was negative, and I was, just it looked a little suspicious to me. But if I see clean parenchyma and clean collecting system, I don't. It's not my standard approach.
Somebody want to answer? ¿Alguien quiere responder esa pregunta, Francisco?
No, I just want to comment that in one of the cases that we operated, the kidney, the tumor infiltrated the liver as well. So we had to do a very marginal resection of the tumor, and obviously the liver was a little bit compromised, but we had a good response with further chemotherapy. So in cases with the marginal compromise, it's probably required a more extensive chemotherapy, and so that's our experience.
Okay, Tony, something to talk?
No, nothing further. I thought the presentations were excellent and I learned a lot.
Thank you very much to all for your presence, and I will invite you for the next presentation with Dr. Carlos Garcia from Mexico. He's going to talk about gastroesophageal tips and tricks repair. Okay, see you the next week. Thank you very much.
Bye, everybody.
Gracias.
Goodbye, everybody.
Gracias.
Thank you, Germán.
Gracias. Bye, Tony.
Abrazo, Dennis.
Gracias de nuevo, muy amable.